So what was I saying? All right, for chapter 39, we're going to cover increased intracranial pressure first, and then we'll go into traumatic brain injury as the exemplar or the example we'll use to explain increased ICP. And then we already finished the tool which we will be using to assess these patients and to monitor for any complications. Okay, let's start first with all right, Mr. Israel, give me 3 things that are inside your head. This is
your brain, the fluid that surrounds your brain so it don't hit against your head, and I don't know, your eyes.
well, the eyes are here. So there are only 3 things in there. Thank you, Israel. So the concept of cerebral perfusion pressure, or this is called CPP. CPP formula is mean arterial pressure minus intracranial pressure. So there are 3 things in your head. We have brain tissue, we have CSF, that's correct, and then we have blood.
Professor, are you writing something? Because we don't see anything.
I thought I was sharing the whiteboard. I clicked whiteboard. There, you see it?
For some reason, I could see it.
I could see it also, but it just went away.
I don't see it. All I see is a black screen that say RE.
No. How come people are seeing different things?
I saw it just fine.
Still no?
Yeah, there it is.
No.
I see it now.
Professor, could I sign out and sign back in? Maybe that's what it is for me.
Yeah, or maybe you're just clicking on the wrong screen. Maybe you're viewing.
No, it's the main screen.
Window.
No, it scrolls through you, I believe.
Okay, but who else can't see my screen? The whiteboard.
I can see.
With a picture of Israel in it.
Yes.
Without the dreadlocks.
Yes. I see everything.
Okay, let's start over. So,
try to
this is intracranial regulation. So, the brain has a slightly unique structure and physiology. There are 3 things inside the cranium, inside the skull. We have brain tissue in there. Then we have cerebrospinal fluid, and we have blood. Brain tissue comprises about 80%, 10% CSF, 10% blood volume. That is already 100%. So, can we accommodate anything else in there? Say we put in a brain tumor in there. Can we do that? Is there room for a brain tumor?
No.
Is there room for bleeding in there? Say, let's put a bleeding and we put a hematoma in there. Is there room?
No vacancy.
All right, it's already 100%. So to put it in perspective, if this is a glass of water, which I filled all the rim, it's already 100%. And then I put 1 drop in there, 1 drop of water. Can I accommodate 1 more drop?
No. It's gonna
What will
stop.
happen if I put in one more drop?
It's gonna one drop gonna flow out.
All right, so this is the concept of there's a doctrine they use in urology. It states that if volume in any of these three components here increases, then volume in another component must be displaced. So similar to this glass of water, it's already full. Let's say this glass of water represents brain tissue, CSF, and blood volume. And then you increase that volume, any one of these. So let's say there's brain tissue swelling, there's cerebral edema. Either there's a remember in glaucoma last semester, we talked about the eye, the aqueous humor, wherein the aqueous humor is constantly produced and constantly drained. You remember that? No?
Yeah.
Yes.
Okay. So the CSF is the same. There are ventricles not in this drawing. Somewhere in the middle, the largest ventricles are somewhere here. There's two of them, left and right. They contain, they're ventricles like the heart, the ventricles of the heart. So there are two big chambers there where CSF is stored, meaning you have production of CSF and then there's drainage somewhere in between. There are canals between the brain, and then the CSF drains down your spinal column. So it is also constantly produced and constantly drained. So it's just like glaucoma. If you have an overproduction of that CSF or a decrease in its drainage, that will increase CSF volume. Or if you have a bleeding, for instance, let's say a hemorrhagic stroke, or let's say a ruptured aneurysm or a busted atrioventricular malformation. Any increase in these, which happens, so let's say you, Miss Jordana sustains a severe head injury. Okay, so let's say she dove into a swimming pool, but there was no water in there. She dove in head first, and then on the way down, she noticed, oh, there's no water. Man, but it's too late. She's already on her way down. So when she hit it, she'll have all three problems. So there's bleeding inside her cranium, there's gonna be swelling of her brain tissue, and there's gonna be obstruction in this drainage of the CSF. So all of these components will increase. So going back again to this cup, a glass of water, if volume in any of these increase, what did the Monroe Kelly say? If volume in any one component increases, then volume in another component must be displaced, right? There's no room here, so somebody has to go. Now, in a structure of a brain, of our skull, by the way, this only applies to an intact skull. Meaning what we're talking about here does not apply if the patient has an open head injury. Let's say somebody got shot, so there's a hole now in the skull, or somebody whacked you with a machete, for instance, opening your cranium, then that this doesn't apply because there is no um, there's no um, compartment to speak of because everything is open. So pieces of your brain are probably on the walls or on the floor. Blood is leaking out. So this only applies if you have a closed head injury. Are we clear so far?
Yeah.
All right. This also doesn't apply. This Monroe Kelly doctrine doesn't apply if the patient is an infant or a small child because they still have open fontanelles, right? So therefore, their brain can accommodate, meaning their brain has more compliance because the skull is not fused yet. You understand? Meaning the skull has room to give. Does that make sense?
Yeah.
Okay, all right. So Jordana is a grown woman. Her skull is intact, no more open suture lines, no more fontanelles to speak of. So it's intact. What is the only opening remaining in her skull? It's
The
this
base?
one right here. Right, we call this the foramen magnum. That is where your spinal cord exits the skull.
Professor, any chance you can type instead of write words?
What? Say it again?
Any chance you can type the words instead of writing them?
No. I'll try.
It's too difficult, then never mind.
What are you trying to tell me?
I cannot correctly spell based on script words.
There.
Were you drinking again, Yan?
So this is the only opening in an adult skull. So it's at the base of the skull, and just like this cup of water here, this is the opening of the glass. This bottom here, nothing can leak out, nor to the sides. This is the only opening. So compared here, this is now an upside down glass. This is only the only opening. So where will displacement occur?
Right there at the foramen
Right
magnum.
here. The spinal cord is already sticking out, so you can't plus it's the spinal cord technically is not part of the contents of the cranium of the skull. We only have brain tissue, CSF, and blood volume there. So what can you displace out to this hole? Because you have increase, so let's say this increases by 20%. Plus 20, this one plus 10%, plus 10% here. You have 40% increase that you have to displace, because we can't. It's already 100% in here currently. So what can you displace? You have 40%.
The CSF.
Even if you displace the entire CSF, let's say it's possible, okay, which is it is not. Let's say you're able to successfully displace the entire CSF out of the cranium. It's only 10%. The total increase is 40. You're gonna have to do better than that.
It can leak from the nose, right?
Yeah,
Well,
it can't. I mean, there's no, like I said, there's no skull fracture.
So won't your head just start to swell?
That's exactly what's happening here. So there's an increase in brain tissue volume because the brain is swollen from the injury. When Jordana hit the concrete floor of the pool, that's what's happening. So she has some bleeding here internally. It can't come out because unfortunately her head, her skull is so rigid, it's quite tough. It did not break.
So wouldn't the doctor like have to make a hole or something to let the pressure out, to relieve the pressure out?
Yeah, we're gonna get there, but right now she's still in the pool. She's still in the bottom of the pool. So what's gonna happen meanwhile? We haven't even called 911 yet. So just like here, is this gonna wait? Is this spilling of this drop here gonna wait for EMS before it spills out?
No.
No. So what's going to, again, we have an increase here. Her Jordana's brain is swollen. There's bleeding in there because her brain was lacerated. There are blood vessels that are broken. She's bleeding inside, but it has nowhere to go because her skull is intact.
Wouldn't it come out of like the ears and stuff? Like the blood and the CSF would come out of the ears?
Again, they'll only come out if there's a fracture of the skull. No, her skull is intact. It did not break at all. This is the only opening. Just like this is the only opening of this glass. So what will come out of here? Something has to come out, right?
Would the brain push out of there?
Okay, which part of the brain will be pushed out?
Oh my God, the medulla? That's at the bottom, right?
Yep. The
Cerebellum.
brain stem's gonna come out. This is the only one. This part here can't come out. I mean, it's all the way over there. This is closest to this opening. So which one will be pushed out?
The one closest.
This one will be pushed out. Now the opening is smaller than the brainstem. So when you squeeze something big through a smaller opening, imagine what that will look like.
It will stuck and make it even worse.
Okay, so it will look like this now. So if you have a small opening and you have a big tissue coming out, it will look like this now. Yeah?
Mm-hmm.
So this section here is this triangulated. This is your door. This is the opening, and this is the brain tissue right here. This is brain tissue. It's squeezed out. It was forced out of here to a smaller opening. What's going to happen to this section right here?
To which section?
This one that was pushed out through the small opening. It's because it was squeezed out forcefully.
Well, I mean, isn't it gonna like have like decreased blood flow because you're closing off like all the vessels that go to it? Because you're trying to squeeze
there
it
will be
out.
ischemia here, correct?
Yeah.
All right. So there will be tissue ischemia there. So will this part of the brain die?
Yeah.
Yeah?
Yeah, we'll start dying off.
Yes.
All right. So there will be ischemia there, and then brain tissue will start to die. So this is the cerebral perfusion pressure that I'm talking about. At any one time, the pressure inside the brain must be somewhere between 70 to 100 millimeters of mercury. This is cerebral perfusion pressure. How you calculate this is by deducting your mean arterial pressure from your intracranial pressure. Now, intracranial pressure is invasively monitored. The doctor will insert a catheter here into this ventricle and then measure the pressure internally. Mean arterial pressure, what is the formula for MAP? What's the formula? So that is the formula for your mean arterial pressure. So 2 times your diastolic blood pressure plus your systolic pressure divided by 3. So, for instance, if your blood pressure is 120 over 60, what is your MAP?
121, 240, 247, 8. Would it be 80?
Okay. Now, this is your MAP. Normal ICP is between 10 to 15 millimeters of mercury. So, if this increases, so after Jordana hit the bottom of the pool, her intracranial pressure increased to 20.
Wait, Professor, what did you say the normal range was?
10 to 15. Don't worry, it's in your book. So if you increase it to 20, and then your MAP is 80, how much you got?
Hold on, repeat that. Oh, that's the 80 and the 20 are the blood pressure.
110. 100.
No, we already have, this is the formula for MAP. We already got the MAP, which is 80. Now I'm going forward with this now. MAP minus ICP. So CPP therefore is what?
Oh, 60.
80
60.
minus 20 equals 60 millimeters of mercury. Is this good or bad?
Bad.
Bad.
It's bad because our normal is 70 to 100. In fact, if this falls below 60, if CPP is less than 60, brain cells die. So there's not enough pressure to perfuse brain cells if your CPP is less than 60. 60 is the minimum, but do you want to be close to that at any one time?
No.
No, because the moment it hits below 60, brain cells are dead. Are you following so far?
Mm-hmm.
All right, so what is your conclusion therefore? If you remember in stroke, what happened to the patient's blood pressure after a stroke?
It increases.
Why did it increase?
Because of the blood volume shunting.
Not really. It's because of the cerebral perfusion. So the increase in blood pressure there was part of the brain's auto-regulation, meaning it automatically raises the blood pressure when there is brain injury. So whether there's a brain tumor there, the patient suffered a stroke, or there was traumatic injury to the brain, the blood pressure automatically rises. So it's you can call it a self-preservation response by the brain, because look at what happens. So if this is my blood pressure, is this good or bad?
The top is good, the bottom a little low.
Okay. What about if from the standpoint of CPP? So if my CPP is 60 with an increase in ICP with a normal or close to normal blood pressure, compare that if my blood pressure was 180 over 100. What is my MAP?
What's that? 200. 380 divided by 3.
80. Professor, it's 80.
I got my calculator.
How'd you get 80? 2 times 100 plus 180, plus 180 divided by 3.
That's 126.66.
Okay, so let's say 126. Let's say your ICP.
127. Okay.
All right, so let's say your ICP is 20. Is that good or bad?
Too high.
What?
Yeah, too high.
Too high.
Too high? No, I mean the higher the better.
Yeah,
70 to 100.
Yeah, and that's 106.
Yeah, so is this good or bad?
It's a little too high. It's 6 over.
Yeah, but is it, I mean, compare this to this one.
Oh, I mean, if you
Compare
compare
this one.
it, yeah, that's better.
This is a lot better. So what can you say by this brain's response? The brain automatically raises the blood pressure during head injury. The objective of the brain, again, is to preserve brain tissue. It wants to maintain good perfusion pressure to the brain because it knows that intracranial pressure rises after an injury. So it automatically responds as a self-preservation response to raise blood pressure in order to maintain CPP. That's why in stroke, if you remember 2 semesters ago, did we lower the patient's blood pressure after stroke?
No.
No, we wanted it to be higher, correct? Of course, this is too high. But why did we want the blood pressure to be around 140/90 or 150/110? Why did we want this blood pressure in stroke? Not really 110, it's 100. Okay. Why did we want this?
Because we wanted to increase the CPP.
Okay, this is what we wanted to preserve. If CPP remains between 700, the brain cells will not die. Are you with me so far in head injury?
Yeah.
Okay, so there's no innocent data here. So when you get a test question, you're given a patient's blood pressure and an ICP reading. What is it really asking you?
What's the CPP?
It's asking you about the patient's CPP. Right now, what is the patient's current CPP? All you need again is the blood pressure and the ICP. If your answer is between 70 to 100, the patient's doing fine. However, if your blood pressure drops and your ICP increases, you can see clearly it has a devastating effect on your CPP. All right?
Yeah.
Any question on this?
What if your CPP is like way higher than 100? Let's say like 120. Is that like
Well, the higher the better.
So even if it's out that range up to 100, like say go up to 130, like that's not bad?
Well, the problem there is not really the CPP, it's now the blood pressure. Because in order to get a CPP that high, that means your blood pressure must be really high.
Right.
Correct?
Yeah.
Yeah, so therefore, it's also dangerous if your blood pressure reaches over 180. Or even 180, we should try to drop it already because that's too high. That's enough to rupture cerebral arteries already. Then you'll have a hemorrhagic stroke. Clear?
Yeah.
All right.
Excuse me, Professor. This is Vivian. Could you please let Umo in? She's in the waiting room.
There's nobody in the waiting room.
She says she's there. I don't know.
I don't see her.
Okay, I will tell her.
All right. Okay. Going back to the brain herniation here. If the brainstem, because the brainstem is closest to the opening, it will be the first one, or I should say really the second, because the first one that will be displaced is some of the CSF, but the next solid structure that is displaced is the brainstem, because it happens to be closest here. What is the function of the brainstem? What does it do in our body?
Make the connection from our brain. Well, travel the signals, make the signals travel.
Well, that's the overall, yeah, that's what happens in our body. But what is the job of the brainstem?
It's it regulates like breathing.
All right, so your vital functions are controlled by the brainstem. Breathing, respiratory rate, heart rate, blood pressure are all controlled by the brainstem. Your reticular activating system, which is the center of your consciousness, is also controlled by the brainstem. So, what do you notice on TV or elsewhere that when you have brain injury, what happens to the patient first? Jesslyn, what have you seen? Somebody gets hit with an aluminum bat on the head. What happens to them?
They knock out.
They go unconscious, right? That's the reason, because the brainstem possibly herniated. It was injured, so it was pushed out as a result of the increased ICP, causing the patient to lose consciousness. That's why our number one tool to use is the Glasgow Coma Scale. We want to see how bad is the injury. So the lower your Glasgow Coma Scale score, then the more serious your injury is. Let's go back now to your textbook. Okay, these are the concepts.
Professor, what page is that?
Yeah,
We are on 817. All right. So let's start with the concept of increased ICP.
Professor, I don't see a screen. I don't know if anybody else see it.
Can you see my textbook?
No.
Yes.
Okay, so it's you, Israel.
Probably me. I don't know.
You gotta click on it, Israel.
Yeah, I'm clicking the screen. I'll just pull it up on like.
Yeah, did you pay your bills?
Yeah.
It's probably why they're blocking you.
I think I did.
Okay, so I explained the Monroe-Kelly doctrine. So there are only 3 things that occupy our skull: the brain tissue, blood volume, and some CSF.
Oh, sorry. What page are we looking at?
817.
All right.
Okay. So the ability of the body to compensate by adjusting these 3 levels is called intracranial compliance. So I estimated here that brain tissue is 80, CSF is 10, and then blood is about 10 as well. So and I just described to you that if there is an increase because of an injury, either an ischemic or traumatic injury to the brain, contents of the skull will increase in volume. If you imagine, do we have a lot of compliance inside a rigid skull?
No.
No. Let's say, remember compartment syndrome? All right, so in compartment syndrome, so let's say I have a fracture of my femur, and then the doctor put a cast or a dressing around my thigh in order to immobilize and reduce the fracture, making sure it's not moved, that it doesn't get displaced. So I'm on a traction, but then he put a tight dressing around my leg in order to apply the traction. And you remember what happened in compartment syndrome? What happened why did the patient have the 6 P's that appear? The 6 P's are what again? What are the 6 P's in compartment syndrome?
Pain, pallor, pulselessness.
Pulselessness, pallor, pain.
Yeah.
Um.
Paralysis.
Oh, yeah, paralysis.
And pressure.
That's okay. Pain, pallor, pulselessness, pressure.
Yeah. And there was poikilothermia, right?
Yes.
Anyway, why did those 6 P's appear? What's causing the 6 P's to come out?
The pressure from the blood buildup.
All right. So there was this dressing or this cast that prevented the swelling to increase. There was the dressing here, or the cast acted like a tourniquet, preventing the tissue from swelling. So if you confine that swelling inside a compartment, but then it doesn't stop the swelling, so as soon as the pressure builds up inside, now it's compressing vessels. I mean, arteries, veins, lymphatic drainage, as well as nerves are all compressed now because of all the swelling. That's why there was the 6 P's. So that's why the pulse is gone. The leg doesn't look pink anymore. In fact, it looks really white. There is pain because there's severe ischemia there. There are paresthesias because there was nerve injury. There was paralysis because there was no more nerve innervation. You with me so far?
Yeah.
So that's why you have the 6Ps that appears because of the severe compression, compressing all your vessels, all your vascular spaces. Now imagine the same thing happening inside the cranium. Does the skull act like a tourniquet? Does the skull act like
Yes.
right? The skull here can act like a tourniquet, a dressing, a tight dressing, a cast, a plaster cast. Okay, so same exact thing. Of all the compartments we have in the body, of course, the skull is the most rigid. We don't have anything else in our body that has something like that. It's only in the skull. So therefore, the pressure volume curve right here. So the pressure volume curve depicts the body to compensate. Again, is there a lot of compliance or compensation that occurs inside a rigid skull?
No.
Not much. That's why we have herniation of the brain. Something has to be pushed out because there's not really a lot of compensation or compliance that occurs inside the skull. So with severe injuries, we are dealing with herniation syndromes here. So what structure of the brain is going to be herniated first?
The one closest to the brain
Base.
was that
The brainstem, right? Okay, so we
Mhm.
said that the brainstem controls our vital functions, correct? That's why when we have a severe head injury and we see this Cushing's triad, what is this Cushing's triad? This is the three sets of symptoms. Number one is increased systolic blood pressure with a really wide pulse pressure, bradycardia. So that's 1, 2, and 3. Irregular respiratory pattern. This irregular respiratory pattern is also called Cheyne-Stokes respirations, no, a really irregular breathing pattern. These three appear because this is now the equivalent of the compartment syndrome. So when there is brain herniation and there is the brainstem is basically dying now because of ischemia because it's pushed out and it's compressed. These three signs appear. That's what we call Cushing's triad. It's a sign of increased ICP, but it's a late sign. This occurs late in the herniation process, and the patient will most probably die in a few minutes. All right, so do you want to see Cushing's triad?
no.
That's a bad sign. And here is the intracranial pressure. See, as your intracranial pressure rises, the volume also increases. Therefore, there will be herniation as a result. If volume increases, so does the pressure. So here are some areas. Let's look at a few parts of our brain, of our skull, sorry. So our skull isn't like a fishbowl. Okay, so we have spines like this. So there are three here. This one, 2, and 3. These are natural spikes in our skull. This divides the brain from, this is called the tentorium, this part right here. We're looking at the brain, by the way, from the base here. So if this was Israel, we would cut off his head from his jawline, yeah, all the way to the back. So let's say we have a really sharp samurai, we cut off his head, and then now we're looking up. So now we're looking, this is his eyes right here. Eyes would be over here, the nose would be here, and this is now the base of the skull. All right, can you picture? So this is called the tentorium. This divides the bigger part of the brain from the brainstem. It separates them. Now there are several herniations here. So this part of the brain, this would be left hemisphere can herniate to the other side. We also have central herniation, where in this part of the brain herniates downward. And then we also have uncal here. This part of the brain is pushed out through here. Or you have, so this is therefore supratentorial, meaning anything above the tentorium, above pretty much your ear and jawline. And this is now called infratentorial, meaning below. When we say infratentorial, we're referring really to the brainstem because there's really nothing else there. So below the tentorium is your brainstem, and then everything else is above the tentorium or supratentorium or supratentorial area. Another, well, you don't really need to, because there will be edema, correct, when there is injury to the brain. You don't have to do these three types of edema because edema is edema. When you look at it on a CAT scan, they look the same. Why they have vasogenic, cytotoxic, and transependymal edema is how the edema formed. So vasogenic is from the severe inflammation that occurs where the capillaries become very permeable. So therefore, remember what happened in burns and in severe sepsis? You still remember that? When the capillaries became very leaky?
Yeah.
Yeah. And then we had ARDS too, right? So that's called vasogenic, meaning the vessels are very inflamed as a result of the injury and then they leak fluid. They can also be cytotoxic, meaning the brain cells themselves died, meaning this is part of when you destroy brain cells, of course they will spill out their contents, so that's going to put fluid in the cranium. So this is still going to cause edema. So regardless of the cause, edema is edema. It will increase intracranial pressure because it occupies space. It increases volume inside the cranium.
Professor, for testing purposes, do you want us to know all these different types of edema or just edema in itself?
No, edema. Just understand the concept that when there is edema, it will increase intracranial pressure. Well, I'm also not testing table 39-1. You can skip that. Skip 39.2 because I don't think it makes a difference because edema is edema. Any swelling increases volume inside the skull and therefore will increase ICP. All right. So the chapter focuses on the assessment, meaning how do you recognize increases in ICP and then what do you do about it? It will go faster when we get to traumatic brain injury because the concept is already explained in this section, because it doesn't make a difference when we go to traumatic brain injury because in that section there is increased ICP because of the injury. This is as far as the Glasgow Coma Scale is concerned about orientation, you know, the verbal. You remember what we did this morning?
Yeah.
Yeah. So as far as the verbal part, best verbal response, these are your questions to establish orientation, whether or not they have any deficits. As I mentioned earlier, the intracranial pressure monitoring is done using a intraventricular catheter. The doctor will be inserting that. And your number one...
Professor?
Yeah.
Oh, never mind. It caught up. Sorry.
Okay.
The screen wasn't moving for a second.
All right. So here's CPP. I said the formula is MAP minus ICP. And I said that if the pressure is below 60, then that means brain cells will start to die now. And this is your normal ICP, is 0 to 15. We really don't want it to be less than 10, but since it says here 0 to 15, then fine. We're not really concerned if the ICP is low. We're really concerned if it's high, for obvious reasons, because there will be herniation if there is an increased ICP. So these are the several methods of monitoring ICP. We have subarachnoid bolt, but like I said, the most advantageous method is the intraventricular catheter, because the catheter will not only allow you to monitor ICP, but it can also help you drain CSF. Meaning, can you lower ICP by draining some of the CSF?
Yeah.
Yes. Okay, so it has two advantages. One is to right here. So this is the IBC. You can disregard the others. You can don't bother with the bolt, the intraparenchymal monitor, because this is the one that we typically see. The doctor inserts an IBC for a dual purpose. One is to not only measure the ICP, but also to drain CSF. So here are the differences between increased ICP and cerebral herniation. Just think about it. Just think of it as increased ICP leads to cerebral herniation, meaning cerebral herniation is a consequence of severe increased ICP. So here, as long as there's no brain herniation yet, you'll see increasing confusion and lethargy. Once you have herniation, the patient is now unresponsive. That's why the scores on the Glasgow Coma Scale here is around 8 or less. Once you hit 8 or less, the patient's breathing is already very low. The respiratory rate is really low. So the patients at that point will be intubated already. Here are your pupillary reaction. Ovoid shape is an oblong shape, like a cat. Have you ever seen a cat pupil? Who has cats here? None? Okay, so
I have cats.
yeah, go grab a cat and then look at their pupil. They have a
You want me to
oblong.
for real though?
What?
Do you really want me to?
Yeah, later. Yeah,
Okay.
grab a cat when you have time. Okay, so look at their pupil and you'll see an ovoid shaped pupil. Okay? It's not like ours where it's a perfect circle. Don't kill a cat. Okay. So please read the difference. And like I said earlier, once this Cushing's triad, these triad of symptoms occur, I mean, it's, it helps you confirm that there is increased ICP, but then the patient will die shortly afterwards. Here is a illustration of the different ways you can monitor ICP. This is again the most popular one, intraventricular catheter, because it's inserted straight into the ventricle, the the right lateral ventricle of the brain. This is where most of your CSF is stored.
And
And here
Professor,
is,
you said IVC is the illness to focus on, right?
yes, right here, it's the gold standard, okay, on table 39.4. So you can disregard the others, just study this one. What are the advantages and the disadvantages? What's the question? Hello? Was there a question?
No, there's no question. I was just saying I got it.
Okay, all right. And here's an illustration. It's actually quite primitive. So when we have an IVC, we the setup has a somewhere here there's a leveler which is not included in the illustration. A leveler is Israel, you do some construction, right? Do you use a level?
Yeah, to make sure that it's whatever I'm putting up is straight.
Yeah, so just like that. So there's a instrument here that has a liquid with an air bubble in there.
Yeah.
So we need that in order to make sure that this catheter is at the same level as the transducer. Because if they're not, the measurement will not be the same. I mean, will not be accurate. So if it's too high, let's say this is not level here, this is up too high, then that means the pressure will give us the reading that it will give us is falsely high. And if the transducer is too low, then that means it will give us a pressure reading that is too low or falsely low. All right. So therefore, and plus our ICP reading that is the basis of our interventions. So if therefore you can't get the ICP reading correct, then the patient will suffer. Right? Because your ICP readings are not accurate. So just make sure, because we need to move this patient. So we will need to make sure it is level at all times. You know, anybody that comes into the room, adjust the height of the bed. Let's say this patient's intubated, right? So we're going to suction, we're going to turn this patient, we're going to clean doo-doo. So during the movement, it will disrupt the alignment. So make sure after you're moving the patient before you leave the room, make sure it is aligned. That way our ICP reading is accurate. This is the collection bag for your CSF. Again, it's not only used as a measuring device, it helps you lower that ICP by draining some CSF. It's not going to be a lot of decrease in the ICP, but it's better than nothing. We'll be talking about some injury shortly. So these are some of the problems that may occur. So let's say you have a let's say, look at this. If an excessive amount of CSF is drained rapidly through an IVC, a subdural hematoma can result. So just be careful about how much you drain at a time. We'll talk about supra and infratentorial. This will be more significant later when we do surgery. When the patient undergoes craniotomy, the post-op positioning of the patient will be different depending if it's above or below the tentorium. That will be later under traumatic brain injury. All right, so let's go now to our treatments. So there are several ways here in order to decrease ICP, not just through the intraventricular catheter drainage. There are other interventions we can do in order to decrease the volume of the three components. So we can either reduce cerebral edema, decrease the CSF volume, obviously that's using the intraventricular catheter. Another is to decrease some of the blood volume. Okay, and then we'll be discussing some of the ways we can do that. All of these, again, our goals are the intention is to decrease the ICP. Another way is to, of course, to maintain a high blood pressure. You have to take note, though, that when these traumatic events occur, there will be other injuries on top of the head injury. So, which will complicate the condition, because if this patient, let's say, loses a lot of blood, what happens to the patient's blood pressure?
It'll drop.
And you already know what will happen to CPP if the blood pressure drops. Because now your mean arterial pressure will also drop, correct?
Yeah.
So therefore, what will happen to your CPP when the
It'll
patient?
drop also.
It'll drop
It will
too.
also drop, right? So always consider all these variables. CAT scan is our standard diagnostic tool, the patient undergoes CAT scan, or if the doctor wants, it'll be an MRI. Questions on the test will be your nursing responsibilities right here on the third column. So about how considerations do you, let's say here, because we use a contrast here, that's why it tells you here to monitor not only allergies to the dye, but also kidney function, right? Because that will, these are nephrotoxic agents, causes intrarenal kidney injury. Checking for pregnancy. So these are precautions you need to take. We also have heart failure, making sure oxygenation, okay, because the patient will be flat here when we put them in the CAT scan machine. And here, if the patient cannot lie flat for at least 5 minutes for the test, then consider another action. So here's the allergy, and here's MRI. So for MRI, basically you're making sure the patient is free from any metal before you put them in there. I'm not testing EEG. This is, we don't really take part in preparing the patient for an EEG because it's the technologist that applies all those electrodes on the head, so you can skip that. I'm only testing CAT scan and the MRI preparation. Let's go now to drug therapy. So we have, remember that there is edema here. So part of the interventions to decrease the edema, of course, is to give diuretics. However, what does diuretics, any diuretic, do to the blood pressure?
It drops
Decreases
blood
it.
pressure.
All right, so keep that in mind before you administer any diuretic. Make sure your blood pressure is at least 140 higher. All right. Now the diuretic used here is mannitol. Mannitol is an osmotic diuretic. It will draw water into the vascular compartment, thereby decreasing interstitial edema. However, like I said, it will also increase blood volume, correct? So technically, while decreasing edema, it may have the potential to increase ICP as well, not to mention dropping blood pressure. Now, an alternate here is high concentration sodium chloride or hypertonic saline. Now, in hypertonic saline, not only does this decrease edema, but it also improves blood pressure. You understand? Because this one, like mannitol, it has about a similar effect because they both work by osmosis. However, the hypertonic saline, the benefit of using this, it will also cause an increase in blood pressure, which can be beneficial in head injury or in increased ICP.
But don't you have to monitor the use of the hypertonic saline when with this kind of patient? Like,
okay, okay, finish your question.
like I remember like what was it, a semester ago, 2 semesters ago, that someone was saying something about like dehydration or like possible dehydration because it's a hypertonic solution.
Right. The patient can develop diabetes insipidus or SIADH here. So they can go either dehydration or overhydration. All you need to do is just monitor it. One of the causes listed there was head trauma or brain surgery or stroke. Those are one of the causes of both diabetes insipidus and SIADH. So just watch for signs of those. Most of these head injury patients, though, they have what's called salt wasting syndrome. And what is the effect of hyponatremia in fluid volume inside the brain?
It would increase the fluid volume?
It actually will cause cerebral edema. So that's another reason why hypertonic saline can be beneficial here, because you can decrease edema, interstitial edema, while replacing sodium loss and also maintaining blood pressure.
Okay.
One thing about mannitol is, I think I mentioned it in class. Did we do ampules at one time? Did we draw from an ampule
No, not yet.
in class, in skills lab?
Not for this semester, no. You showed me how to open it.
Okay. Anyway, mannitol forms crystals. So you really should be drawing it up using a filter needle. That way you don't administer any emboli during administration. So make sure you draw it up with a filter needle and protect it from light, etc. Okay, besides the hypertonic saline or mannitol, here are some of your interventions. So things you can do to decrease ICP is to do not elevate your head of the bed higher than 45 degrees. Doing so increases the chance of increasing ICP because you will now increase intrathoracic pressure. And blood pressure also drops the higher the head of the bed position. So the consensus is anywhere between 30 and 45 degrees. All right. So this position facilitates drainage of blood from the brain down to your jugular and into the right atrium. If you elevate it any higher, that will actually decrease venous drainage because now your intrathoracic pressure is higher because your hip is also flexed, right? When you're in a sitting position. So once your hip is flexed, therefore the diaphragm is forced to put pressure against the thorax, increasing intrathoracic pressure, decreasing venous return, increasing ICP. Do you get all that? Do you get that? The rationale?
Yeah.
Okay, because it's all about facilitating drainage. You don't want, basically what we're trying to do here is to prevent blood from draining into the heart from the upper parts of the body, shoulders, especially from the head. Okay, so we do not want any hip flexion. All right, so again, 45 degrees or 30 degrees is actually better. 30 to 45 degrees, no higher than that. This will keep your neck neutral and therefore no hip flexion, and therefore venous drainage is facilitated.
Professor, I have a question.
Yeah.
Like how we're talking about this. The patient would have a drainage system in place, while you're keeping the head at a 45-degree angle.
Intraventricular catheter.
Okay. So with all that being said, they still have to stay at the 45-degree angle, like with the drainage system in?
Yeah.
Okay.
Another is the oxygenation of the patient. Remember, we have brain herniation here, correct? So CO2 levels will rise here. So we don't want that happening because CO2 will cause, is a potent vasodilator. So this will actually increase intracranial pressure by increasing blood volume. However, when we oxygenate the patient, we also do not want to hyperventilate either. Because look at this, the consequence of hyperventilation global vasoconstriction, which will now cause ischemia to the already injured brain tissue. So we want to make sure the CO2 never goes higher than 35. I know the normal range is 35 to 45, correct? But we don't want it to be any higher than that because this is a critical patient. These are again your here's a what is the safety alert box. Again, do not do this, okay? Do not do 90 degrees. Highest head of the bed elevation should be
45.
30 to 45. 45 would be your max. If the patient, despite all these efforts, we cannot stop the increase in ICP, even if we oxygenated the patient by intubating them and put them on a mechanical ventilator, we position them 45 degrees. We have a intraventricular catheter measuring ICP and draining CSF. None of these are helping enough, so the patient will have to undergo Hemi Craniactomy. This is now a removal of a section of a skull. You've probably seen people like this, wherein it looks like their head is flat or actually indented on one side. Have you noticed that? Because they literally remove a piece of the skull. So therefore, there's a part of the head that is missing a skull. So that area will only be scalp. It's all scalp. So therefore, nothing is holding it. So there's no shape to speak of. So that's why it kind of indents. Okay, it looks like you have a crater on that part of the head. Does that make sense?
Yeah.
Yeah, because there's no skull there. You remove the skull, but then you suture the skin back. So when there's no skull, so that part of your head will be caved in. Can you imagine that?
Yeah.
All right. They usually do a marsupialization after this procedure, meaning they will put this piece of the skull is either put in a tissue bank or in the patient's abdomen. If we put that in the patient's abdomen, this is called marsupialization. What is a marsupial?
It's a animal that carries its baby in its pouch like a kangaroo.
Okay, like a kangaroo. Okay, yeah, exactly. So we're like doing it. We're turning the patient into a marsupial by putting that skull inside your abdomen. You can feel it under the abdomen, just under the skin, just to keep it alive, because your body will grow blood vessels and keep that part of your skull viable. It will remain alive. That's the best way instead of putting it in a tissue bank. I mean, it's better if you keep it in the patient. Plus, we don't lose it. We know it's there. You understand? Yeah, because somebody might lose this in the tissue bank. Although I'm not saying they lose pieces of skulls there. I mean, who's gonna steal a skull, right?
Skull thief.
Yeah, right. All right. So other interventions are if there is really no the ICP continues to rise. We did the craniectomy already. Now the patient will be put in a coma. The purpose of a barbiturate coma is to decrease the metabolic activity as well as the demands of the brain, meaning you're resting the brain. Cool it down. Don't make it work too hard. We're going to put the patient into a coma on purpose. It allows for brain tissue to heal because it's not working as much. There's less electrical activity, less stress on the brain. It will heal. Drugs, this is part of the intubation already. We will discuss these drugs again later when we get to airway management and mechanical ventilation. So these are your standard medications given to a patient who is intubated and put on a mechanical ventilator. So they receive pain medication, either morphine or fentanyl, not both, okay? Either one or the other. They'll either receive this, Versed, or propofol, so either midazolam or propofol right here. So these are your sedatives. So you have sedation and you have pain medication. We assume that they're in pain. We don't wait for. Plus, if you learned from last semester, is there really outward signs of pain? Because we said pain is a subjective experience, correct?
Yeah.
And these patients are unconscious, they're sedated. So how do you know that they're in pain? Are vital signs proof of pain? Like we learned last semester?
It's not 100%,
No.
but
Yep.
it's
No. Yep. You can't. Basically, it's subjective, so you can't ask the patient to prove that they have pain. Let's finish up now.
Professor.
Yep.
Pain could slightly raise your blood pressure, though, right?
Say again.
If you have pain, that could slightly raise your blood pressure.
Yeah, but you can't. Yeah, while that's true, it doesn't occur in all patients. Plus, the fact that this patient had head injury, is the blood pressure going to rise anyway?
Yes.
Yeah, so again, you can't use vital signs to prove the presence or absence of pain here.
Okay.
All right. So neuro checks every 1 to 2 hours. Vital signs monitoring, the same frequency, 1 to 2 hours. Temperature. Okay, this wasn't mentioned earlier, but here it is. What is the effect of high temperature on blood vessels?
Vasodilation.
Okay, so will that increase blood volume to the brain?
Yes.
Will that increase ICP?
Yes.
Okay. Some hospitals even do therapeutic hypothermia because of that reason. CPP, same. Everything is done 1 to 2 hours here. So here, CPP, you constantly monitor and calculate your ICP. I mean your CPP. Cardiac rhythm, because this can lead to cardiac output drop and therefore will decrease blood pressure and then decrease MAP and decrease CPP. I know this affects blood pressure, so we don't want any hypotension. If that happens, make sure the doctor is notified so we can give fluids in order to maintain blood pressure at 140 or 150 systolic. Monitor sodium. Again, we don't want any hyponatremia here because that will increase the likelihood of cerebral edema. Monitor electrolytes, especially again sodium, because remember this patient can develop either diabetes insipidus or SIADH. Here's the thing about the CO2. We don't want any hypercarbia, so maintain oxygenation. And to do that, we need to draw ABGs. And here is a summary of your interventions. So positioning, oxygenation. This is the sedation and the using either midazolam or propofol and your pain medications. Here's your mannitol or hypertonic saline, and making sure CSF drainage is constant. Here's the intervention for hyperthermia or fever. And that's it. Oh, if a patient undergoes craniectomy, remember there's no skull, so they're at risk for injury here. If this patient falls and they hit that portion with no skull, what's going to happen to that brain? No protection.
Professor, for those types of patients, wouldn't you have like protective gear on their heads, like the helmet?
Yeah, right here, helmet.
Oh, okay.
Yeah, it's not a heavy helmet. Okay, it looks like a bicycle helmet. It's colored
It's
brown.
like a padded helmet.
Like a what helmet?
It's like a padded helmet. It's like cushion, like all around the head.
Yeah, it looks like a bicycle helmet, not like a football helmet. It's just a regular helmet, just to protect the head. You put that every time, whenever he is out of bed. All right. While the patient is in the bed, no problem. But when you, because they start rehab as soon as possible, so we do put this patient out of bed. Plus, also to prevent DVT, so we begin um, um, physical therapy. Make sure they have a helmet on whenever you get them out of bed. That's it. We'll continue next week for TBI. So quiz next week will be on ICP, increased ICP.
Professor, quick question. So if the increased ICP is due to hemorrhage, how